also talk about TKA bearing surfaces, and my job today is not to convince you what to do, what not to do, but rather help you understand and the philosophy of what we're dealing with, right? So these are my disclosures. So TKA needs bearing, right? So over the 30 years, we have had so many types. And this is all because they all have subtle differences, and each one is evolutionary better. You guys are fortunate enough that you have some of the designers of these polys sitting with us amongst us today. So I would encourage all of you to go pick their brains and understand the philosophy of what their vision is, and rather than what's good, what's not good, right? So what are our options, right? So all the previous speakers have fantastically described this. I'm not going to read this out to you. You guys are very familiar with what a CR is, what a PS is. The goal of this talk here is hopefully focus on the primary side of the bearings, right? So what are some of the old bearing issues we're faced with? Clearly, post-wear, right? Osteolysis, clunk, bone loss, and kinematics, right? So post-wear, any of you have done revision knees, this is, you've seen this day in, day out, right? Whether it is from the medial lateral, whether it's post being worn out, you can go in the PS knees and all you see is a little stub and a marble in there, right? So osteolysis, right? We've tackled this by, with our highly cross-linked polyethylenes, vitamin E, fantastic innovation, the better post, better understanding of the locking mechanisms, right? The secure bone to implant fixation has also helped us understand and increase the longevity of our bearings, right? So, what about patella clunk? We had a discussion about this earlier, right? If you look at the 90s, 15, 10%, you see this treatment arthroscopically, here's the problem. You don't see this. This problem has essentially been resolved. You don't see this in modern designs, right? Kinematics. Now I can sit here and show you papers to support CR, PS, CCK. You can find whatever, this is literature as well, research, support anything you want to do, right? But again, my goal is to help you understand the philosophy, right? So what's gotten better? So revisions, yes, the implants have gotten better poly, oxidatively stable, cross-linked, better locking mechanisms. Once again, the implant designs. This all has helped us push the envelope for TKAs in younger patients that have been, post-traumatic or early rheumatoid or whatever inflammatory arthropathy, right? So our understanding of kinematics has increased, right, dramatically over the past few years. So we know that the traditional PS and CR designs are known to demonstrate paradoxical motion, where we have the anterior translation of the implant and the deep flexion. I don't know if this video is going to play, but we can try it. Probably not. Okay. But anyways, so the kinematics knee has been extensively studied by Dr. Freeman and his crew, right? And they've been widely published. So what do we know? What is this, right? So we have the medial Baldwin socket, highly conforming, large contact area, low contact stress, right? So when you read these papers, when you understand, when you look into it, right, every kinematics experiment is also a stability experiment. What do I mean by that, right? So kinematics is when you put energy into the knee and you look at how it moves. What is stability? When you put energy into the system and you look at how it doesn't move, right? So our goal in these, right, is to achieve stability and mobility, right? When you have the ball and socket, shallow joint, 2 discs, we're going into what we call the universal joint, right? So when you have an experiment, right, that explains all these observations, we know how the knee moves, then that's considered complete, right? So your classic teaching, you teach your residents when the tibia internally rotates with flexion, right? So when you bend the knee, tibia rotates. How do you explain this picture? Tibia is externally rotated in deep flexion, right? So we don't really know what we're talking about. So I say that design should follow to stability and not force kinematics, right? There is not one path of motion to the knee. The knee is free to move in many different ways, but it is guided by the compliance of the 2 compartments, or the designs of the bearing and the implants itself, right? So in conclusion, in 2024, not 95, we want something that is fast, reproducible, bone preserving, lower risk of flexion instability, less noise. Nobody likes a clunky knee, and kinematically equivalent. So I ask, why make life harder than it needs to be? Thank you.